Welcome to the Ventilator and Pulmonary Mechanics Chalk Talk series, where we're learning how ventilators work and how to work with ventilators. I'm John McManigal. Let's get started. In the first talk, we built up a mental model of a ventilator and used Ohm's law of resistance to figure out the pressure and flow over time graphs for the most basic ventilator modes, pressure control and volume control. This time, we're going to fill in some of the details of compliance and resistance, and then do a little bit of differential diagnosis that you'll need when you're working a ventilator. We will start with a quick review of resistance, which you'll remember is the relationship between pressure and flow. We'll then define compliance as the stretchiness of the lungs, or more formally, the volumetric stress-strain relationship. We'll look at peak and plateau pressures and how they relate to changes in compliance and resistance. And finally, we'll take a look at our first complication of mechanical ventilation, which is auto-PEEP, or sometimes called breath stacking. To start, let's pick up where we left off in the last talk. We had a patient connected to a bellows by some ventilator tubing. Throughout this talk, we'll be working with a baseline of volume control mode. That makes some of these concepts easier to illustrate, but of course the concepts themselves apply in any ventilation mode. Remember that in volume control mode, during inspiration, the ventilator delivers breathing gas to the lungs at a constant volume flow rate, which is shown in red on the flow graph. To deliver that constant flow, the pressure in the circuit, shown by the green line of the pressure graph, has to stay a constant amount above the pulmonary pressure, shown in the dotted blue line. And remember that you can't measure that blue pulmonary pressure, but we do know it's there. Last time, we defined the relationship between pressure and flow to be resistance. Let's take a closer look at that now. If you have a tube with pressure P1 on one side and P2 on the other side, then the volume flow rate, indicated by V dot in yellow, is proportional to the difference in pressures, delta P. The constant of proportionality is the resistance R. You might remember from some time back in school that Poiseuille's law tells us that the resistance to flow through a tube is proportional to the length of the tube and inversely proportional to the radius of the tube to the fourth power. Airway length doesn't really change that much, but that radius to the fourth power is huge. It means that if you have a little baby with bronchiolitis and their airways are swollen up to half their normal radius, the resistance to flow has increased by a factor of 16. Resistance is also proportional to the viscosity of the fluid, breathing gas in this case. Viscosity is represented here by the Greek letter eta, and viscosity doesn't matter much clinically because breathing gases at body temperature all have a pretty similar viscosity. What does matter is that this whole paradigm is only true during laminar flow, which is nice ordered flow through a tube. Resistance is much higher in turbulent flow, which is more chaotic with collisions and eddy currents. There's actually no good mathematical solution for resistance in the turbulent case. You have to do computer modeling or experimental work to know the resistance for sure. But it's high, and it's nonlinear, and it's bad. You're more likely to have turbulence in high-resistance, high-flow states like emphysema or an asthma attack or a bronchiolitic child. Alright, so the most important things to take away about resistance are, assuming laminar flow, which we will for the rest of this talk. First, resistance defines the linear relationship between pressure and flow. And second, resistance is inversely proportional to the radius of your airways to the fourth power. Now, let's shift gears to compliance. If you direct your attention back to the pressure and flow time graphs for volume control ventilation on the left side of the screen, we know that during inspiration, we're moving a constant flow rate of gas into the lungs via the circuit. We've been assuming that the pulmonary pressure, the blue dotted line, is increasing as lungs fill up with breathing gas. And we know intuitively that that's true, but we need to think mathematically about the relationship between the volume of gas in the lungs and the pulmonary pressure. That relationship is called compliance. If you consider this blue balloon over on the right, it is being held open by a difference in pressure. In this case, P2 inside the balloon being higher than P0 outside the balloon. If you distended the balloon a little bit further with more gas, the pressure P2 would increase, and the volume of the balloon would also increase. The proportionality constant between them is compliance. So in a high compliance lung, you don't need much pressure to move a good tidal volume, which is a good thing. Whereas in a low compliance lung, you need more pressure to move the same tidal volume, which is bad. We'll keep using compliance here, but just in case you run into the term, elastance is the inverse of compliance, which some people prefer for mathematical simplicity. So high compliance is good, high elastance is bad, but they're just multiplicative inverses. So this equation lets us formalize a little bit what is going on over in our volume control graphs. As a constant rate of volume is being pumped into the lung, the pulmonary pressure, that blue dotted line, increases in a linear fashion. So at this point in time that I'm drawing in yellow, if we look down at the flow graph, we've moved an amount of air equal to this yellow shaded area into the lungs, so the pulmonary pressure is here. As time goes on, at the end of inspiration, we've moved this entire tidal volume of gas into the lungs, and so your pulmonary pressure has increased to this point. And the slope of that blue pulmonary pressure line is entirely dependent on your pulmonary compliance. Now, just like calling resistance a completely linear phenomenon was a little bit of a simplification, calling compliance linear is also a simplification. If you were to actually look at a pulmonary pressure volume loop, what you would find is that down here at the origin, when you're first recruiting alveoli, the curve is a little bit more flat, then there's this nice linear region, and then there's going to be this kind of beak-shaped area where you can add more pressure, but you won't get much more volume because you've reached your lung capacity. And there's also hysteresis to the curve, which means that the shape of the graph as you exhale is a little bit different than when you inhale. This graph is one of the explanations for why we add that positive end expiratory pressure, or PEEP. We'll set our PEEP about here on the pressure axis to try to avoid the lower atelectatic part of the graph. We'll do most of our ventilation in this nice linear region of the graph, and we won't let our pulmonary pressures get too high, both to stay out of the nonlinear beak-shaped part of the curve, and more importantly, to prevent lung injury. Where this lower limit is, and where this higher limit is, we'll get into a bit more when we talk about spirometry and ARDS in a future lecture, but for the foreseeable future, just like we did for resistance, we're going to assume that we're staying within this linear compliance domain. Alright, so now we have resistance, defining the behavior of gas flowing through the airways into the lungs, and compliance, defining the pressure buildup in the lungs as that gas is delivered. If we put them together, we have the difference between P1 and P2 equals resistance times volumetric flow, and you have the difference between P2 and P0 equals 1 over your compliance times your change in volume. We can add both sides of these equations together, the P2's cancel out, and you have P1 minus P0 equals your flow component, which is resistance times flow rate, plus your distension component, which is 1 over compliance times change in volume. So to simplify all of this and get rid of all the P1s and P2s, let's look at this with the variables that we're used to. Your circuit pressure is equal to resistance times volume flow plus 1 over compliance times volume distension of the lungs. So this really is your fundamental equation that defines what the pressure is doing in your ventilator system. It's providing flow through the endotracheal tube and airways, and then it's providing pressure to distend the lungs with your tidal volume. So there's a clinical diagnosis question that comes up every once in a while, maybe in an intensive care unit, maybe in an operating room. you'll see that the peak pressure on your ventilator circuit pressure, that's this point at the end of inspiration, where the circuit pressure is highest, is getting too high. And the question is, if your pressures are getting high, you know either your resistance has gone up or your compliance has gone down. And either one of these is a bad thing, but they describe two different pathologies with potentially different treatments. If your resistance has gone up, that represents obstructive disease, an asthma exacerbation, COPD flare, swelling in the airways, or maybe a mechanical obstruction like a kinked endotracheal tube. On the other hand, if your compliance has gone down, that demonstrates restrictive pathology, either the classic sort like pulmonary fibrosis, more dynamic like pulmonary effusion. It could be external, like increased abdominal pressure restricting the movement of the diaphragm, or it could also be a mechanical issue. If your endotracheal tube tip migrated into your right main stem bronchus, you'll have lost the compliance of the whole left lung. So it's important clinically to distinguish between a resistance problem and a compliance problem. And there's a trick you can perform on any modern ventilator to tease out the difference, and that's called an inspiratory pause or inspiratory hold. So if we look to the left at our standard volume control breath, the ventilator delivers a set volume flow rate for a certain period of time. Your circuit pressure increases to force that flow rate into the lungs. At the end of inspiration, the circuit pressure immediately drops back down to the positive end expiratory pressure, and that triggers expiration. Instead of running that normal breath, any ventilator has the ability to perform a breath with an inspiratory hold. We start with a normal inspiration, but at the end of inhalation, instead of going immediately to exhalation, the ventilator will briefly stop all gas flow by closing both the inspiratory and expiratory valves, causing an inspiratory hold state. What this causes on the pressure curve is the normal beginning of the breath, with an initial uptick in pressure to initiate inspiratory flow, then an increase in circuit pressure to match the increase in pulmonary pressure. But then, at this point where the volume flow rate is zero, the circuit pressure required to maintain zero flow is exactly equal to the pulmonary pressure. That's because you need to maintain the pressure related to compliance to keep the lungs distended at their tidal volume. But if the flow rate is zero, then compliance is the only term remaining in your circuit pressure equation. So what you'll find in your ventilator circuit pressure graph is that your circuit pressure immediately decreases to the pulmonary pressure, stays there for a fraction of a second, and then to end the pause, the ventilator will allow that pressure to drop back down to PEEP, and expiration will proceed as normal. We label the pressure during the inspiratory pause the plateau pressure, and we label this peak at the end of inspiration the peak pressure. So peak pressure and plateau pressure are just the specific names for different points on the circuit pressure graph. And if we take a look at what would happen in a high resistance situation versus a low compliance situation, we can see how the peak pressure and the plateau pressure are helpful for teasing out which one of these is the problem. We'll go ahead and start in the high resistance situation. So the ventilator, starting down on the volume flow graph, is going to do what it always does. Start at zero flow, go ahead and give a constant flow breath, then give an inspiratory pause, and then allow for expiration. The circuit pressure at the beginning of all of this is at PEEP, in equilibrium with pulmonary pressure, and then the pulmonary pressure, as the lungs are distended by the tidal volume, is going to increase as normal. However, because your resistance is high, the delta between pulmonary pressure and the circuit pressure needed to drive this constant flow rate, if resistance is high, flow rate is constant, the circuit pressure will have to be high. So your circuit pressure is going to jump way up like this, and then continue to increase in parallel with the pulmonary pressure. At the time of the inspiratory pause, because flow is now going to be zero, the circuit pressure is going to return down to the pulmonary pressure and hang out there for the inspiratory pause. When it's time for expiration, the circuit pressure goes right back down to PEEP and allows for expiration. So what we see here is a very high peak pressure, but a normal plateau pressure. And the reason is that with a high resistance, to maintain this constant flow rate, you need a constant but very high delta between your circuit pressure and your pulmonary pressure. But as soon as, in your inspiratory breath hold, your flow rate goes to zero, this whole term of the equation becomes zero, and all you're left with is the compliance volume term. Let's contrast that with what happens in a situation where your compliance has decreased. Starting down on the flow diagram, just like before, you start out at equilibrium at end expiration. The ventilator forces a constant flow rate breath into the lungs, settles on an inspiratory hold for a moment, then allows for exhalation. Just like before, at end expiration, the circuit pressure is at PEEP in equilibrium with the pulmonary pressure. The difference this time is that as air is forced into the lungs, that low compliance means that pulmonary pressure increases more dramatically. The circuit pressure increases to a normal delta over the pulmonary pressure, and then keeps increasing in parallel with the pulmonary pressure. During the breath hold, circuit pressure decreases to pulmonary pressure and stays there, and then circuit pressure drops down to PEEP for exhalation. So here we have an increased peak pressure and an increased plateau pressure. And this all makes sense because the problem with our whole equation, when compliance is low, has nothing to do with the resistance term, so has nothing to do with the difference between pulmonary pressure and circuit pressure. The problem is that the pulmonary pressure itself is increasing too rapidly, and the compliance in the equation remains whether flow is zero or not. So one more time, if peak pressure is high, but plateau pressure is normal, that indicates a resistance problem. If peak pressure is high and plateau pressure is also high, then you have a compliance problem. As the last topic for this chalk talk, I want to talk about something called auto-PEEP or breath stacking. It's a complication of mechanical ventilation, and it's best understood looking at these same pressure and flow graphs, which is why we'll get to it right now. The fundamental problem in auto-PEEP is insufficient expiration time, either because of increased airway resistance or just because there's too little expiration time on the ventilator. So let's look at how this happens. We will stay in volume control mode. Looking down at the flow graph, we're going to start a new constant flow inspiration. The circuit pressure will increase as necessary to provide that flow, and then will continue to increase to match the increase in pulmonary pressure, and then we'll cycle to expiration, and the circuit pressure decreases back down to the PEEP. Pulmonary pressure will begin to decrease because of expiratory flow. But what if, before expiration is complete, the ventilator triggers another inspiration? And again, the two primary causes of this are that expiration was too slow because of increased resistance, such as in obstructive disease, or because you set your ventilator to have too short an expiratory time. So expiration terminated early, and now the ventilator, in volume control mode, is going to force air into the lungs at a constant volume flow rate. So this same delta between pulmonary pressure and circuit pressure is going to have to be established again on our next breath. So circuit pressure jumps up over pulmonary pressure and climbs as the pulmonary pressure again climbs from that point. Now it's time for expiration, so the circuit pressure drops immediately to PEEP, pulmonary pressure starts declining due to expiratory flow, but again, too early, it's time for inspiration again. The ventilator delivers a constant flow breath, the circuit pressure jumps up above pulmonary pressure, it again climbs as the pulmonary pressure climbs, and what you find is that your peak pressure is continuously increasing because your lungs are not emptying with every breath. So this is what is known as auto-PEEP, because even though you think your positive end expiratory pressure is down here, which is true for the circuit pressure, unlike in a well-formed breath, the pulmonary pressure hasn't gone down to reach the set PEEP by the end of expiration. So your auto-PEEP is the difference between what you set your PEEP to and what your actual end expiratory pulmonary pressure is. At some point, you reach equilibrium here and the pressure stops climbing, but the problems with auto-PEEP are, first, as your pressures climb, you risk lung injury, and second, that pulmonary pressure is transmitted into the thorax and can result in hemodynamic compromise because you'll get less cardiac venous filling. The ways to avoid auto-PEEP or breath stacking are, most importantly, to make sure that your expiratory times are long enough, which means decrease your respiratory rate and decrease your I to E ratio or your inspiratory time, all with the goal of increasing your expiratory time. You can also decrease your tidal volume with the idea that if you're pumping less volume into the lung, you'll have less gas that needs to come back out during expiration. Now, all of these variables are in balance with other goals of ventilation, which is why sometimes this becomes a problem. But remember that the fundamental way to prevent auto-PEEP is to have an adequate expiratory time. Acutely, if you find you have a patient who you suspect has auto-PEEP complicated by hemodynamic compromise, with blood pressure decreasing, tidal volume failing, ventilator pressures rising, one thing you can do immediately is to disconnect the expiratory limb of your ventilator. That will allow a full exhalation with hemodynamic recovery, and then you can figure out how to correct your ventilator settings from there. All right, so to sum up this lecture, we talked about resistance, which governs the relationship between the difference between circuit and pulmonary pressures and the flow rate. So higher resistance means you need more pressure to get the same flow. We talked about how resistance through a tube is inversely proportional to the fourth power of its radius. So even a modest decrease in your airway diameter can cause a big increase in resistance. And we talked about how resistance goes up a lot in turbulent flow. We talked about compliance, which is the relationship between pressure and volume distension of the lungs. And we talked about how that can be estimated pretty well as a linear function, but does become nonlinear at very low and very high distension. We talked about the peak pressure and the plateau pressure, and use those to diagnose an increase in resistance as an increase in peak pressure without a big change in plateau pressure, and on the other hand, a decrease in compliance has an increase both in peak pressure and in plateau pressure. And finally, we talked about auto-PEEP or breath stacking, which is a complication of mechanical ventilation. Fundamentally, this is caused by insufficient expiratory time, either because the time itself is too short or because expiration is too slow due to an increase in resistance. We try to prevent this by having lower respiratory rates, lower I to E ratios, and lower tidal volumes. And if auto-PEEP does happen, it can lead to hemodynamic compromise, which can be acutely resolved in an emergency by disconnecting the ventilator circuit. Thank you so much for sticking around, and I'll see you next time.